All right. Okay, it's 7:01. In the interest of time, let's get started. Good evening from New York City. It's actually a rather warm day here in New York. It was sunny and it went up to 80s after a few days of cool uh, late summer, early fall. Hope you're all doing well and looking forward to talking to you in the future. Tonight, we have a fantastic session. We truly have an all-star cast tonight, and we have fantastic cases and also the most prominent expert in the field. We are very pleased to have our discussant, Dr. Bird, will introduce. So without further ado, we'll give you the baton. Ken, if you please go ahead and start the
Sure.
session.
Yeah, thanks everybody for joining us tonight. The theme for tonight's tumor board is skull-based malignancies. We were initially going to focus solely on endoscopic versus open approaches, but I think over 3 cases there may be some repetitiveness, so we decided to broaden it a little bit to some other areas of controversy, including extent of surgery, non-operative treatment, and adjuvant therapy. As in other tumor boards, we'll have 3 cases, each lasting about 20 minutes. Our case presenters today are Dr. John Delmeda, Associate Professor at the University of Toronto, Matt Geltzeller, Assistant Professor at Oregon Health Science University, and Jonathan Girantano, Assistant Professor at Georgetown. Our esteemed faculty discussants are Dr. Zuka Sargi, from the University of Miami, Dr. Carl Snyderman, Professor of Otolaryngology and Neurologic Surgery at Pittsburgh, and Dr. Jack Fan, Associate Professor of Radiation Oncology at MD Anderson Cancer Center.
Matt, you first.
Can everybody see that? Yes? Yeah. Cool. Hey, everyone. I'm Matt Geltzeller. I work in Oregon at OHSU. Yeah, let's just jump right in. I have a case of a 72-year-old woman who presented with a left ethmoid mass. She had 4 months of epiphora and slight blurring of her vision. Mild diplopia, no nasal obstruction, epistaxis, or any cranial neuropathies, no neck masses, and a reasonable Karnofsky status. On exam, she had no extraocular motion restriction and no cranial neuropathies and no neck masses. And on rigid endoscopy, she had a mass filling the left nasal cavity and middle meatus.
For discovered first place, how did the patient present? With the epiphora?
She presented because of epiphora and blurry vision. She presented to an outside, her primary care doctor, who sent her to an ENT, who sent her to me. So here's her CT scan. You can see a mass filling it's a CT scan in the coronal plane. You can see a mass here on the left side eroding her nasal bones, extending back into her orbit on the left side. Doesn't extend too far posteriorly, but there is some erosion of the nasal bones, and it's immediately adjacent to the lateral lamella.
Great. Let's pull the expert real quick. Zuka, what? Oh, well, I was gonna say, what do you start with? Do you start with MRI up front or CT, or you routinely get both?
So oftentimes patients come to us with non-contrasted imaging studies because they're, because of underlying concern of chronic sinusitis. So if you have a non-contrasted CT, I usually complete with a contrasted MRI. If you have a CT with contrast, this helps you tell what's secondary retention from what's tumor. As you probably could see on the previous CT scan, you really cannot tell what's retention versus what's soft tissue mass on non-contrasted CT. So I typically get both for sinonasal tumors, oftentimes a CT without contrast for the bony anatomy and an MRI with contrast.
What would you do? Do you routinely get MRI and CT, or contrast or no contrast?
Me? Carl, I think they're asking you.
Okay, I didn't hear my name called, sorry. Generally, I mean, if the tumor is limited to the sinus, nasal cavity, then I'm going to start with the CT. And even if it's extending outside the sinuses, I'm probably going to start with the CT with contrast. And I would do a skull-based protocol up front for navigation in the event that I want to use it for surgery. And then almost, if there's any extension beyond the sinuses, then I'm also going to get an MRI, especially if I think there's intracranial extension or extension into the orbit, because I'm going to want to see that interface.
Continue.
All right.
You only get CTA for these cases, or just if there's intracranial involvement?
So I'm sorry. So I would, if there's skull-based involvement, I'm going to get a CTA. If it's extending into the anterocranial fossa, I'll get a CTA. Or if it goes filling the sphenoid sinus, then I want a CTA to better show the course of the carotid artery. Otherwise, I would just get a standard CT with contrast for nav.
All right. So
Go.
as you can see, I got an MR. So we're kind of scrolling through. This is an MRI post-con with FATSAT in the axial plane. And you can see the lesion here up front that is encroaching into the orbit. It is either pushing the periorbita medially or it's invaded the periorbita, but the extraconal fat doesn't seem to be invaded, nor does the medial rectus. You can see, though, it also extends out through those nasal bones like we saw on the CT scan, and there's a little bit of a non-clear border in the soft tissue of her skin anteriorly by her nasal bones and frontal sinus. So I took a biopsy of that in my clinic, and it came back as a poorly differentiated squamous cell carcinoma. I got a PET scan for staging, which was negative. So I would stage this as a T4A-N0 squamous cell carcinoma of the paranasal sinuses. So
stop and ask questions by all means.
Yeah.
Okay. Yeah. Go ahead.
Yeah. So my question for the panel would be, what would you guys do for a patient that presented in this manner?
Before you go forward, quick question, practical question. Do you do these biopsies in clinic, in office?
For me personally, I generally do. My patients travel sometimes a long distance to come and see me, and as a practical matter, I find it relatively straightforward to biopsy these things. If I look at it and there's any concern that or the patient's a little skittish, I'm concerned I may have an issue controlling epistaxis. I don't. If I'm worried at all that it's like an encephalocele or I may get a leak, then I won't. But I generally like to know what I'm dealing with before I go to the operating room. So I try to biopsy things in my office when feasible.
Question from our esteemed colleague, Jeff Liu. Do you routinely send for P16 nowadays?
I do as well. Now, not on the biopsies, usually just on the main specimens, on the surgical specimens. Although sometimes my pathologist here will do it on ones routinely when I send them, but I don't ask for them to go back and do it when they don't do it from outside. We're recognizing more and more that P16 is associated with sinonasal squames.
Open it to the panel. Let's see. Is Dr. Fan on?
I'm here. Yes.
Okay. Hi.
Hello.
Welcome. All right. So what would you recommend? Okay.
So I would ask my esteemed surgical colleagues what they would think of as far as the resectability of this tumor, and go from there. I think sometimes in cases where we're looking for a functional preservation of organ, that we would consider induction chemotherapy and base treatment based off of response. But in this case, being a squame, and these tend to be very radiosensitive, that I think giving primary chemoradiation is very reasonable if surgery is not preferred.
Thank you. Zuka?
So there are a few things that I would like to point about this case. First of all, the epicenter of the tumor seems to be equally the lacrimal sac, and the agarnazi. So it's very hard to tell whether this is a tumor that started in the anterior-most ethmoids that went into the lacrimal sac, or whether it's a tumor from the lacrimal sac extending into the ethmoid. There are a lot of similarities between malignancies of the lateral nasal wall, the anterior ethmoid, and the lacrimal sac. And I know P16 was mentioned, and we know that a subset of those tumors are actually HPV related, and I agree those tend to be very radiosensitive. If we want to talk about staging this tumor, this is T4A disease in the ethmoid. There is no significant skull base involvement. So according to the NCCN guidelines, the preferred treatment modality would be surgery followed by adjuvant therapy, and an alternative acceptable treatment would be with concurrent systemic therapy and radiation, either starting with induction chemotherapy or definitive chemoradiation. And we could discuss the benefits of each of the treatment modalities.
Usual philosophy in Miami.
So for a case like this, so to be able to manage those tumors, it's very important to have very good support. And in that particular case, I think support from ophthalmologists and oculoplastic surgeons is going to be key, because whether you embark on an orbital preserving surgery or whether you decide to treat this patient with definitive non-surgical treatment modalities, this patient is likely to have issues with the eye. And it's not about saving the organ, it's about saving a functional eye and not having to deal with chronic, painful, not functioning eye or a facial fistula next to the lacrimal sac. For that particular patient, I would strongly recommend induction chemotherapy. If the patient responds, I would consolidate with chemoradiation.
Thank you.
Baba, can I make a point about P16 status? I think this is an excellent point, because we all know that in oropharyngeal cancers, P16 status portends a better prognosis. The jury's still out in non-oropharyngeal sites whether that's the case, but certainly I would agree with what was said, that we're seeing that with sinonasal cancers that are P16 positive, squamous cell carcinomas, that there is early data to support that there is a prognostic difference. And I 100% agree that these are much more radiosensitive. In fact, in Toronto, our treatment approach is a little bit different than most centers, where we do radiation first and we do planned combined surgery after radiation. And we have a bunch of cases where P16 positive tumors, you go in after the radiation with your planned resection, which was the original disease volume, and you have no viable residual disease. So these are highly radiosensitive tumors, these P16 positive.
Why do surgery at all after radiation?
Well, it's part of our treatment paradigm. So we do upfront neoadjuvant 50 gray, which is not definitive dose, with planned combined surgery. But that's a good question. I mean, that's just part of the combined.
Time. Let's give the last word to Carl. Dr. Sandra, what would you do?
I'm not sure it'll be the last word, but as mentioned already, there are a lot of acceptable options here. There's no clear winner on this list. First of all is really being clear about the pathology. I don't rely on outside pathology reports. I want an experienced head and neck radiologist doing the interpretation. Poorly differentiated carcinoma, I worry about some of the more aggressive variants. If this were a nut carcinoma or an I&I deficient carcinoma, then I'm definitely going to head towards chemotherapy. This is a resectable tumor as it is right now. I do think it would require a combined approach, endoscopic and external transorbital, because there may be skin involvement. You need a good margin on the lacrimal sac. And we would involve our oculoplastic surgeon to really clear the orbital margins for us and make sure we don't take anything we don't want to take. So my goal here is preservation of the eye. And I think it's a toss-up between doing surgery first versus induction chemo followed by surgery. Your question is, if you get a CR from radiochemotherapy, why do surgery? My philosophy is that even if you get a negative pathology report, it doesn't mean there's not viable cancer there. And if you wait for the tumor to recur, then you've lost the opportunity to save that eye. So even with a CR with radiochemotherapy, in cases like this, I would often go ahead and do a cleanup surgery just to make sure we have clear margins on the orbit and then we're not going to lose that eye from a recurrence.
2 votes for surgery. Excellent. Okay, Matt, let us what you decide.
I'm going to skip through. Yeah, so I'll give my little plug for this at the end. I'm just going to skip through. So we did induction chemotherapy and then surgery. You'll see, but just for the sake of time. So after 2 cycles,
chemo. What's your agent? You know, we're going to be oncologists here. So chemotherapy is like you're going to have surgery. What does it mean? What do you do? We
did 2 cycles of cisplatin and docetaxel, Q3 weeks. That was what was elected by the medical oncologist. So though TPF is also would be more standard. We did 2 cycles every 3 weeks, and then we did follow-up imaging after those 2 cycles. And you can see there's an MR, but I don't have it available. So that would give us a slightly better response. But you can see almost a near total response. The only area of concern is right in here. So we had a very good response, but not a total. It's unclear whether or not that's just residual bony destruction from the tumor or if that's residual viable tumor.
So you go just a very quick yes no. Zuka, at this point, would you recommend radiation or chemo RT or go surgery?
Chemo radiation.
Okay. John Dalmeida, what would you do? After 2 cycles, excellent response.
I would go ahead with surgery for a couple of reasons. One is to, as Carl mentioned,
Hold yourself for 1 second.
Yeah.
So, okay, surgery. 1 was surgery, 1 was chemo RT. Let's see, Dr. Fan, what would you say?
Chemo radiation, I think, is very reasonable here.
Okay, let's ask Ken Bird. Ken has been very quiet. What would you do, Ken?
I think I would go with surgery at this point and then consolidate afterward with radiation if needed. I think that, I guess in my experience, doing radiation or chemoradiation at this point, you're likely to end up with a similar defect, a fistula between the sinuses and the skin, and I would rather treat it up front surgically than on the back side.
All right. So, and then Carl, what would you do? Would you go surgery or chemo?
Surgery followed by RT.
Okay. All right. Matt, go ahead.
The fact that this tumor responded to induction chemotherapy, it almost doesn't matter what you do. This patient is going to do well. So I think
that's very good.
The key message is the response to induction chemotherapy in those cases is a very significant prognostic indicator. And you could do chemoradiation or you could do surgery followed by adjuvant therapy. This patient is much more likely to do well than someone with the same exact tumor that does not respond to induction.
Correct. All right. So sorry if I'm cutting anybody. I apologize. It's just I want to get going. These cases are fantastic, and I always try to put myself in the shoes of fellows and those questions. So just want to make sure that everybody understands that there are different ways of doing this. Go ahead, Matt.
Yeah. So so we discussed this with the patient. We discussed it at our tumor board. We debated CRT, like consolidation with CRT versus surgery, and the patient elected. We kind of presented both ways. The patient elected for surgery. So here's a quick video. I did this case with my oculoplastic surgery colleagues, as was mentioned. We did a combined open and endoscopic approach. So we started with re-resecting the area of skin that we were concerned was involved initially. So we approached it externally down to the area of nasal bones that was concerning. I'm just going to try to move through. And then we performed a medial orbitotomy and separated the orbital contents from the periorbita that was potentially involved. We then performed, we did some exposure endonasally, resecting the middle turbinate and the inferior turbinate. And then opening up her sinuses widely, not only to potentially clear any residual cells, but also to be able to monitor the area for recurrence or opening up by her uncinate into her ethmoids and opening up into her agranasi, opening into the frontal sinus. And into her maxillary sinus.
Sorry.
And then we're resecting her lacrimal, her nasolacrimal duct and up to the lacrimal sac.
That's your normal speed of operating, correct?
Yeah, the case normally takes about 15, 20 minutes. And then we're completing that lacrimal sac cut, working through the opening, working through the medial orthotomy.
So this video is fantastic, and if you don't mind, at some point we would like actually to have a technical session, and all of you guys should come back and show us videos. But in interest of time, we have to move on. Can you show us what happened and what you found?
Sure. No problem. Yeah, the reconstruction on that was kind of interesting. We had to use a pericranial flap and do a whole bunch of other stuff for internal lining. But, whoop. Sorry, guys. So the final pathology revealed no viable tumor, as was suggested could potentially happen. And so we offered the patient no additional treatment at that point, or radiation. We did not offer her CRT because we didn't find any viable tumor, but I would like to actually ask the panel,
Sure.
Would you, in this case, if you had no viable tumor found on your final pathology, would you even offer this patient radiation, or would you just monitor her?
Great question. So let's see, Zuka and then Dr. Steinerman, and then John, you go last, and then you start your presentation right away. So Zuka, what would you do?
So, we don't have any data to back up any statement we make with that regards. If we consider her induction chemotherapy as first step of treatment, and this would have been consolidated either by radiation or by surgery, assuming that you gave her a good oncologic resection, then you could say that your definitive treatment was with surgery. I would be very hesitant not to radiate this patient because I don't think I have any literature to back this up.
Got it. All right, Carl?
I would agree with radiation therapy because you never know about your margins with the orbit.
Good, sounds good. And then John?
Yeah, I totally agree with Zuka and Carl. I think there's one consideration here is with the delivery of adjuvant therapy is what was the reconstruction here? Because if you have a solid reconstruction and you're happy it's going to withstand adjuvant therapy, that's a good thing. But if you're questioning whether or not that thing's going to break down, if you have a free bone graft, that's a sitting duct for a big nasocutaneous fistula. So that's just one consideration. But I agree oncologically, I would go with radiation here because we don't know about the margins, and this thing can be splattered all over the place after induction.
All right. So while you are putting up your presentation, Matt, can you say what you did for recon?
Yeah. So first of all, thanks everyone for letting me present. This was really fun. I'm looking forward to the rest of the session. We reconstructed, I elevated a pericranial flap on that side for internal nasal lining, and then I carved a cadaveric rib graft for rigid reconstruction, and then primarily closed the area. We also stented the nasolacrimal duct, and we had resected the periorbita, so we used alloderm to reconstruct the medial orbital wall. And she did great. She had a little bit of diplopia after surgery temporarily, and then she got radiated, and she's doing fine now. She definitely had some issues with epiphora, so we had to deal with some nasolacrimal stents that we put in, and she did fine with that. And she's NED. She's almost 2 years out now.
All right, thank you. Can you stop your screen so John can put up the screen?
Yeah, I'm sorry.
All right, fantastic case. Thank you again.
The one other thing I would say, thank you guys, is that we are trying to create some more content on the AHNS website. We're starting something called the Skull-Base Oncology Case Series. This case is the first one. You can see there was a bunch of stuff I skipped over, going over a lot of the oncology regarding this. That's up there now, so you guys can go and watch it if you like. There's a second one that should be published any day.
Okay, Matt, sorry. We're running out of time. John?
All right. Can you see my slides okay?
Yes.
Yeah, so thanks again for the opportunity and for putting this session together, everyone that's involved. I'll just briefly run through the history. It's really more of a question about management. I think in skull-based sort of case conferences, we always talk about the primary site. And one of the things we don't talk often about is nodal issues. And so I want to really focus in on that with this case. It's a 55-year-old lady that I saw just before the pandemic hit who actually presented with progressive left eye proptosis and diplopia on lateral gaze. She was really otherwise quite healthy. She came from Northern Ontario, so very simple type person, but just really kind of understood the gravity of the situation. When we examined her in clinic, she had a fair bit of proptosis and dysconjugate lateral gaze. And an obvious nasal mass on endoscopy that was basically sort of, visible just anteriorly. This had been biopsied before I had seen her, and it was squamous cell carcinoma. There was no P16 status on it. So I just want to go through, I don't have a beautiful video of the scan, but I'll scroll through some of her imaging. This is her coronal MRI. So I'll try to go slowly here. And let me just do that one more time so everyone can see the primary site disease. So you can see, so obviously proptotic on that left eye, disease invading the intraconal fat, extending through the lamina papricia, up into the frontal recess, right up to the cribriform plate. You can see a little bit of dural enhancement there, but no obvious dural nodularity, which is obviously the more sensitive sign for dural invasion. And disease extending along the medial rectus all the way back to this sort of sphenoid sinus. And this is her neck imaging. So glands there, really not much to write home about. Nothing was really called on the imaging. So maybe a question for the panelists. I don't want to steal sort of Ken's and Babak's job. If you guys want to ask questions, feel free.
No, you go ahead. You're a very, very good moderator. I've seen you. So just go ahead and ask and point to people who you want. And but you have to move on and finish because Jonathan has a great case.
Don't worry, Babak. We'll get through it. So Zuka, maybe for you, just what defines, I think this is a great question because there's several definitions about what constitutes orbital invasion. What are your criteria for when you would even consider the orbit involved and potential need for exoneration?
So there are multiple grading systems for orbital invasion in the literature. I think everyone agrees that if the bone is involved, it's a negative factor that becomes worse when the periorbita is involved, and then that becomes worse when the fat and the orbital structures are involved. According to the AJCC staging, the orbital apex is what defines T4B disease. So once the disease gets to the posterior intraconal orbit is where you have the most advanced disease. And those cases are usually the cases where you would need to sacrifice the orbit when you have intraconal invasion in the anterior orbit. We do not operate anymore on T4B disease when the orbital apex is involved for most malignancies, except potentially for something like adenoid cystic carcinoma.
Carl, do you, I know what you're going to answer, but maybe just for the panel, what do you do if if the lamina is involved, the periorbit is involved, and there's orbital fat involvement without rectus muscle involvement? Is that a patient that you can preserve an orbit on?
Well, I used to think it wasn't, but my feelings have changed over the years. I found that with aggressive orbital resection, even taking one of the extraocular muscles, we can preserve useful function of the eye and have a control rate that appears to be as good as orbital exoneration. So I'm much more likely to do induction chemo in those cases, but even so, I think you can do a more aggressive resection. If there's this tumor on the scan that has an ugly margin in the orbit. It's not a nice pushing margin. This is one that I think requires an orbital exoneration.
Yeah, I think, I just wanted to highlight the changing definition of orbital involvement. And there is some literature out there that people can do piecemeal fat resections in the orbital fat. this would have been heresy 10, 20 years ago, but the definitions are really changing. Maybe I can sort of switch gears in terms of the management. And maybe I'll start with the surgeons and then go to Jack. How would you guys manage this disease? I mean, clearly orbital invasion, no question about it on the imaging. Clinically, orbit's involved. How do you manage this?
So I would offer orbital exenteration if I'm positive that this is going to clear the margins as one possible treatment option, although I would strongly suggest that we start with induction chemotherapy. I am concerned by the margins at the cribriform plate, and I worry that even if we exenterate the orbit, we may end up with positive dural margins. And I think what will determine this patient's prognosis is whether or not the anterior skull base dura is involved, not so much the anterior orbit. So in our practice, this patient would be recommended to get induction chemotherapy.
John, in the interest of time, if the focus on this is the management of the neck, maybe we can skip forward to that.
Sure.
Yeah.
And so with the primary resection, Zuka and Carl, I know you said induction, but when you get to surgery, which you eventually will, what are you going to do with the neck? Are you going to do anything with the neck?
So I'll quickly say, I saw a small level 1B node on the left side, and I don't know if you're going to mention this, but I saw it on the MRI next to the submandibular gland. NCCN guidelines are to address the neck if you have N positive disease. And I would discuss with my radiologist and potentially get a PET CT. If we were to manage this surgically, the patient would likely need a free flap. And if we're doing a free flap, the patient would probably get a neck dissection, in particular with what we see on the MRI.
Carl, neck dissection?
Yeah, I'm staging most of my patients with PET CTs these days. And if that's negative, I would not do a neck. This generally in this location would be a low yield for occult neck disease. So I would only operate the neck in the presence of radiologic evidence of metastases.
So the patient did have a PET scan preoperatively, and there was no uptake in the neck. Jack, if you're involved in the care of this patient, clinically N0 neck, Zuka actually very astutely pointed out a small level 1B node. This is PET negative, N0 clinically. Radiographically, the radiologist didn't comment on that 1B node. PET negative, would you manage the neck? And if so, what levels?
Yeah.
Yeah, absolutely. In this case, I would treat the neck bilateral.
Do you guys routinely radiate the neck in these sinonasal cases at MD Anderson?
Yeah, for the squames and for the high-grade sinonasals, we will. The neuroendocrine, the SNUCs. For the esesial, it depends. But for this particular histology, we would treat the bilateral neck, treat levels 1B through at least 3, sometimes 4, and include the retropharyngeal nodes.
The one thing I would add for all the present is that there are 2 points that came up. One was the margins ugly, which is a surgical term, and the other one is look at the nodes. And that's one of those things that all of us would benefit to look at our scans very carefully ourselves. Just the fact that your radiologist is involved or not involved in tumors, there are nodes in there or not, you have to look at it. And this will happen to you, to all of us, if we rely completely on radiologists. But you do have a different eye. So go ahead, John.
Yeah, so I just wanted to point out, I think everyone's familiar with the NCCN guidelines on this, but skull-based tumors, ethmoid sinus, exceedingly rare to get disease in the neck. In fact, I saw recently, I just was looking up the literature, and in a large series of about 800 patients, 1.6% rate of metastases, and you can see here that, as I think Zuka mentioned, in clinically positive disease, certainly we would say resect the neck, but in N0, I typically stay away from it. So what do we do? Well, COVID hit right after I saw this patient. I usually would have done this upfront, surgery upfront, because to me, there's no prospect where I would not want to exonerate that eye given that radiographic appearance. Even if I gave this patient induction chemotherapy, I don't think I'd ever be happy that the margins on the orbit would be clear. So I would typically offer this patient upfront surgery, but once the pandemic hit, we weren't able to do that. We were backed up into sort of extreme, only urgent cases. So they got preoperative radiation. I just want to say that that preoperative radiation and surgery is different than doing surgery after failed chemoradiation. It's a combined treatment approach with 50 gray instead of 70 gray, where surgery is actually part of the package deal. We do that at Princess Margaret Cancer Center. So the patient got preoperative radiation, 50 gray and 25 fractions, and a planned combined open anterior craniofacial resection with orbital exoneration. I tend to put free tissue in here. So I put a lat flap in there to reconstruct the orbit and also to line the skull base. We also put pericranial flap on the, we resected the skull base in dura. The patient had persistent disease after radiation in the orbit, in the ethmoids, in the dura, with clear dural margins, clear margins at the primary site. Now, what was interesting, and Zuka really picked up on this, is that little perifacial node. So I actually didn't do a neck dissection on this patient because they were clinically N0, PET negative. I took out I do a small incision just below the submandibular gland to dig out the facials. I leave the gland run intact. I dig out the facial artery and vein and tunnel my pedicle into the neck. And I took out 3 perifacial nodes because one of them was a little, bigger on the scan. And sure enough, that one had a focus of 1 millimeter focus of metastatic squamous cell in a perifacial node. So the question for the group now is, now what do you do? So it's almost like we haven't done a proper neck dissection. In talking to my radiation oncologist who communicated with the other rad-oncs at PMH, the neck was actually not, they elected to avoid radiation to the neck. What do you do now?
All right, let's ask Jack. Jack, what would you recommend? 1 out of 3 microscopic focus.
Yeah, in this case, if the neck wasn't radiated, we tend to be more aggressive. I would radiate the parotids and all the way down the ipsilateral neck. I wouldn't treat the bilateral neck in this particular case. It's interesting. We've had a rash of folks that, I'm sorry?
He said there's might be some feedback. Okay, so you would radiate.
I would radiate.
And you also do parotid. Let me just ask you, this is a fantastic case again, that's interesting. So, John, why do you guys, when you were doing radiation, why not chemo RT? Why not adding chemo to it?
Yeah, we can. You can do that with preoperative radiation strategy as well. Usually because it's 50 gray, you only get 1 or 2 cycles in there.
Yeah.
But because we're operating after it, I just find that the wound healing is much poorer in the context of chemo RT before surgery. So in select cases, if I'm really worried, we'll add chemo in before as well.
Okay. So just okay, you want to finish your presentation?
Just a quick question, John. Can you clarify the rationale for neoadjuvant radiation? Is it to shrink the tumor to facilitate resection, or is it to spill the tumor from a immunological exposure opportunity? Because the neoadjuvant radiation hasn't been used in a while, so I was curious about your rationale.
Yeah. Brian O'Sullivan is a big proponent of this approach, and I like the rationale in certain situations. So with preoperative radiation, and Jack can speak to this as well, the dose is the gross tumor volume. In our institution, in the adjuvant setting, they treat a margin around the resection bed. So you get actually a larger margin of radiation. So when you're worried about things like optic nerve sparing and sparing dose to the nerve, preoperative radiation actually limits dose to the nerve and the chiasm because your target volume is just the tumor on imaging, not the surgical bed plus volume, plus expanded isotropic expansion around that. So that's, and also there's dose sparing because preoperative is 50 gray versus 60 gray or 66 in the adjuvant setting. So that's the rationale. And I like it, particularly if we're close to the optic chiasm. So you can spare dose.
That guy, you could do more radiation after surgery now because now you have residual disease.
Well, they spared the neck. So what we went on to do is we had a discussion about this patient in Tumor Board, And then what I want to show you is this is the post-treatment films. The primary site was clear. You could see the lattice pulled a little bit away from the skull base, but the orbit is properly obliterated. Now this showed up. So the disease was on the left. Now we've got a contralateral node that's PET positive that showed up on the post-surgical scan. So what I did is we had a discussion about tumor board. We thought, this is still fairly small. We talked about radiation to both necks, both parotids, and the retropharynx bilaterally versus sort of surgical staging. So we elected to do bilateral necks on this patient and an IPSI parotid. This I just did yesterday, by the way, so I apologize. I don't have the final path on it. But I just thought this is an interesting case to talk about really unpredictable patterns, management of nodes, retropharyngeal nodes, and contralateral nodes as well. So it's I can always bring that back at some point.
Yeah, please give us an update. The fantastic case. One thing I would say, I'll go back to what Zuka said, that this tumor has already presented himself. This one, I'm sorry, but this one is probably not over yet. Persistent disease after radiation, spreading bilateral, N2C, we all know it's bad. All right, excellent. And very interesting, and it'll be really interesting to hear more about this perioperative radiation. I think that if that takes off, I'm just going to retire. All right.
Thanks, John.
Go ahead, Jonathan.
We'll pass the ball to Jonathan.
Okay, let me see if I can share my screen. All right.
Very quiet. So if you guys have any questions, please let us know, and you can ask it on the chat directly to me or Mike Moore, and then we can present it to the panel. Go ahead.
All right, so hopefully this is showing up for everybody. So thank you for having me. I'm Jonathan Gerentano. I'm an assistant professor in the Department of Otolaryngology at Georgetown. And this is a case that our anterior skull base team, myself along with Tim DeClotz and Amjad Anazi, our neurosurgeon, did a little over a year ago. So the case, HPI is a 68-year-old male who had initially presented in January of 2019 to a local community otolaryngologist in the DC area with persistent right-sided epistaxis, facial pain, as well as new onset of facial numbness for the past 4 months. That ENT had obtained CT imaging, which showed a destructive mass in the right maxillary sinus, and he was subsequently taken to the operating room for an endoscopic biopsy. Otherwise, a fairly healthy guy, history of hypertension and flutter, has had some of the blue plate special surgical procedures in the past. Lifelong never smoker, does not drink alcohol, works for the US government, like many folks in DC do. His only medication is metoprolol. So on his initial physical examination reported by his community ENT, he has this kind of fixed dilated pupil on the right side, which he reports is essentially a lifelong abnormality from where he was struck in the face with a baseball bat as a child. But he has full vision on the right side, all extract muscles are intact. And there's no obvious masses within the nasal cavity on anterior rhinoscopy. No lymph nodes in the neck. So these are a few cuts from his preoperative pre-biopsy CT scan that I'll run through. So we start the axial cut on the left. So we start seeing this opacification in the ethmoids with maybe some demineralization of the lamina papricia on the right side. And soon this large mass eroding through the lamina there into the orbit, kind of going towards the posterior maxillary wall.
Destruction, obviously, correct?
Yeah, lots of bony destruction through the both posterior maxillary wall and the orbital floors. We'll see here on the coronal cut.
All our presenters came tonight with real tumors.
Yeah.
Even a non-skull-based surgeon can see them.
So big tumor. The skull base itself, the fovea looks intact. There was no presentation of CSF leak at the time of him seeing this community otolaryngologist. And the results of his biopsy was a malignant melanoma.
In the office or in the OR?
And the OR, yeah. Operative biopsy in the OR. So,
The OR when you went in.
yeah, so we did not biopsy him at Georgetown. He was biopsied by this community otolaryngologist. And staged, had distant staging of the chest, imaging of the chest, demonstrated no evidence of any metastasis, no nodes in the neck. So he was initially staged as a T4, you know, A versus B, depending on whether there was skull base invasion, N0, M0, malignant sinonasal melanoma.
See that
So I was going to stop here.
Just logged in. Okay, so yeah. Ivan, can I put you on the spot? What would you do for melanoma? How are you?
How you doing? Oh, I've been listening the whole time. Okay. I'm sorry, I did just look away. So it's in the orbit. Where else does it extend?
It's in the orbit, starting to go through the posterior maxillary wall towards the infratemporal fossa. The ethmoid root fovea looks intact.
Yeah. Well, I think obviously first thing, you know, you got to stage this. You have to get a PET scan to see if there's any distant disease anywhere, so you know exactly what you're dealing with. Obviously, the outlook for melanoma patients is really dismal, but every once in a while, you know, you win with the treatment. So if my philosophy is if you can treat this and get it out of there and not really do too much harm, then you should go for a complete resection. I think if it's going to be really deforming, you obviously have to look at the patient's health and status otherwise, you know, if they're elderly or if it's a young patient. If it's going to be really deforming, then I sort of think twice about what we're going to do. So I have to be really hard pressed to do an orbital exoneration in a patient like this. And I do know there are some centers that are starting with immunotherapy now for melanoma, but we're not quite there yet unless it's a widespread disease. So I think something that's limited here, and I have to take one more look at it to consider if I'd actually go and do an endoscopic resection on this or try to do an open resection and clear the disease, and actually advocate for radiation after that as well. That's pretty extensive into the orbit there. I don't know if we could.
I don't think anybody gonna have any much hope in this orbit. Okay,
Yeah.
so you still prefer surgical up front if possible.
If you can get away without really deforming the patient or hurting them.
All right, let's ask Matt Gelslider. What would you guys do at OHSU? Melanoma.
Yeah, like Dr. El-Sayed was saying, these are really tough because there really isn't any good induction options either, and chemoradiation is poor. I mean, no matter what you do, the data shows that there's not really much of a change in survival no matter what treatment modalities you pick. I would want to look at an MRI to better evaluate to make sure that I don't see any intracranial invasion, but assuming that that's negative and it's N0, I would opt for surgery. I would exonerate this patient and then put a free flap in. And if the neck truly is N0, I would leave the neck alone and then use adjuvant radiation.
Looks like Jonathan has the MRI.
Yeah, so this MRI was obtained after the initial biopsy, which again showed this large mass within the center within the maxillary sinus. It did not look like there was any obvious brain involvement or dural invasion. It's abutting the dura at the olfactory recess, but there was no obvious, intracranial invasion at that time.
That looked like there's a plane on the orbit. Did I see that incorrectly? John?
It looks like there's a plane, but yeah, there was question of whether the periorbita was still intact and holding off the tumor there. But it was obviously going through the orbital floor and lamina into the orbit.
So I do think this is someone we'd have a really discussion about starting with immunotherapy, actually, if we really felt we couldn't get out of the orbit. But it's a discussion on every case.
Jonathan, was there a PET CT done? Kind of in the interest of time, was there any metastatic?
Yeah, there was a PET CT. No metastatic disease. All within.
Great.
I would just
So
comment
quick
that the
question
brain
for-
MRI has a dual role. It identifies the tumor within the dual relationship, but it also requires a brain MRI would be appropriate for metastatic workup. So it has a dual role.
Absolutely. All right. So quick question for Zuka and then Carl. What would you? So Ivan said, maybe immunotherapy or surgery up front. Zuka, what would you do in Miami?
So a couple of points. First of all, you see the big difference between interpreting a CT scan without contrast and an MRI. So for people who want an example of how MRI and CT scan are both essential, especially in those cases, this is one clear example. Two, even though there is, there didn't used to be any evidence for systemic therapy, there are now many clinical trials, and there are more and more medical oncologists who have experience and expertise in treatment of cutaneous melanoma who are getting interested in working with mucosal melanoma. So we do have a melanoma expert, and we get him involved on every single case of mucosal melanoma. This is a case that needs to be discussed in a multidisciplinary fashion. Those patients tend to recur, and the recurrence is most often systemic, not so much local regional. So I would.
What's the philosophy at Miami in 2020? 10 seconds.
So 10 seconds. If this is a pedunculated lesion with a small base of attachment that I think I can resect, I would offer the patient surgery. If this is a broad base attachment involving the skull base, the orbit, and I fear either field cancerization or not being able to clear the margins, I would not offer surgery.
What about causing harm? Like having to remove the eye in this situation?
I don't think removing the eye is, like, if you have to remove the eye to clear the melanoma, this is non-surgical disease. This is disease.
And that's what I meant. If it's deforming or it's going to harm the patient, because most of our patients recur within 18 months. Just surgery and radiation.
Do in Pittsburgh.
I agree with most of what's been said. Get the medical oncologist involved right away. But this is systemic disease by definition, in my opinion. This patient most likely going to die of systemic disease, but the role of surgery is local palliation. I'm trying to prevent a big, ulcerating tumor from growing out of the patient's head. So yes, I would do aggressive surgery. I would try to be extradural if possible. If there is dural involvement, it's easy to take a margin on the dura. But my goal is to get a complete excision of the tumor followed by radiation therapy. And even though I know this patient very likely will develop diffuse mucosal spread of tumor at some point, oftentimes that's asymptomatic for patients and they live a long time without bulky disease. So I think there's great value in aggressive therapy for local palliation.
Carl, would you do an exoneration if there is clear orbital invasion?
Yes.
Can I bring up a couple of points that we haven't really talked about, Babak? I agree that the medical oncologist is the most important person in this case. And we haven't talked about mutational status on this particular tumor. So I would type this patient, see if they're BRAF V600E positive. Very unlikely in mucosal melanoma, much more commonly in cutaneous, as we all know. But if they are BRAF positive, you can give them combined MEK inhibitors, BRAF with the brafenib tremi. The other thing is there's an ASCO clinical practice guideline that all the fellows should read on melanoma. And they talk about mucosal melanoma. Right now, combination therapy, Ipi and Nivo, is the treatment that is accepted as first-line treatment for this form of disease, or single-agent immunotherapy in the adjuvant setting. So that would be Ipi or Nivo, Pembro or Nivo in the adjuvant setting. But all of this depends on what the mutational status on the patient is. So if they've got mutations, they may have a targetable agent. So some things to think about.
Do you check mutations in Toronto now?
For mucosal melanoma, I do. They're very rare that you pick up anything, obviously. It's usually immunotherapy that is involved in their treatment at some point.
I think this patient would best be served by a clinical trial, and a lot of the clinical trials now include stage 3 and stage 4 mucosal melanomas. So
conversation, we all understood that that there are a lot of unknowns about melanoma. So mucosal melanoma is still a miserable disease.
I just
and
posted
I hope all the audience appreciate the insights from all the experts, from Ivan, from Carl, John, and others. Jack, I will ask you what you do at MDS, but I would like Jonathan to finish the presentation, and then we'll discuss more.
Sure. So, I think everybody's, great input along the right track. So this patient actually went outside of the DC area, went to one of the, leading cancer centers in the nation. He had a multidisciplinary treatment team. The skull-based surgeon there did not feel that he was going to be able to resect it to negative margins. So the patient was started on 4 cycles of IPI and Nivo beginning in January of 2019. And then he had new treatment, new imaging obtained in May, so 3 to 4 months later. And now this is his follow-up MRI imaging after 4 cycles of IPI and Nivo. And I'm not exactly sure about the mutations. I'd have to dig deeper in to see what all that.
I still see a tumor.
But unfortunately, on IPI and Nivo, there was progression of disease. Yeah, and new progression extending up through into the cribriform and through the ethmoid roof, with more mass effect on the eye.
Hasn't got chemo, hasn't got radiation, but has got 4 cycles of immunotherapy, and he is clinically progressed, correct?
Correct.
Okay, Jack?
Yeah, this is a tough situation. I think I agree with everyone that we would want to put this patient on, can you guys hear me, on a clinical trial in the most ideal setting. I think in a case where the patient does get upfront surgery, we also have done hypofractionated radiation, given it's a melanoma, and this moves them to adjuvant systemic therapy faster. And so this would be typically 5 fractions over QOD over 2 weeks, and to really move them onto the therapy that's needed. Now, in this particular case where they've already have progressed on immunotherapy, then I think we would look into other systemic agents. If it's non-resectable, then from a standpoint of radiation, it would be palliative. We have had some response with more, again, hyperfractionated approaches, but my hopes wouldn't be too high in this particular case.
Okay, so I would say I'll leave it to Jonathan, but I think that for the interest of time, I think these are one of those cases that's kind of borderline, maybe not resectable. So what did you decide, Jonathan?
Yeah, so he came down to us. Actually, he was referred to us just to visit our proton center for possible consideration of proton beam radiation. And our radiation oncologist presented him at our multidisciplinary tumor board. And despite the progression, we still felt that with aggressive surgical treatment, we could at least try to clear margins and then consolidate with postoperative radiation therapy. So this was CT. So he was taken for a combined approach, open with endoscopic assisted resection of the anterior skull base with infratemporal fossa resection. The video on the left was you can see the large anterior skull base resection with anterior lobe of the brain. And then I did a chimeric anterolateral thigh free flap with a large piece of vastus muscle to help seal the skull base, and then fat fascia from the ALT to reconstruct the orbit. He initially had a little bit of a complicated post-operative course. He actually self-extubated the morning after surgery after getting a light in the ICU and had to be re-intubated, but did quite well after that. Did make it onto radiation therapy, underwent full 70 gray of radiation therapy. I actually took him recently to remove the monitoring skin paddle. Overall had a nice cosmetic result from the orbital exoneration, and actually is back at work in the government, back traveling abroad and doing his governmental duties. So he's now 13 months out from treatment of his adjuvant radiation. He's 25 months out since his first onset of symptoms. Currently disease-free. We know that, despite that, the chance of him recurring and, metastasizing distantly is still quite high. But we were able to get him at least back to work and without the pain of this melanoma. So we're, for the moment,
after immunotherapy, correct?
Correct.
Okay. All right. So it's 8 o'clock, but if you guys have time, just let's discuss a little bit. If anybody has any comments regarding melanoma, these are rare cases, challenging cases, fantastic results. You cannot ask for anything better. But I'm curious to hear others' comment for 5 minutes.
I posted a link in the chat. It's a little bit dated. It's a head and neck study from, it's a study in head and neck from 2005, but it's one of the largest multi-center retrospective studies looking at sinonasal malignancies. And the only take-home message there is that the histology or pathology of the disease drives outcome, and margin status is a big contributor to that outcome, and specifically mucosal melanoma has the worst outcome of all the histologies listed there. So that is a great paper to refer to when you're trying to figure out where your patient's histology lies on the good-bad spectrum. Yeah. So I just posted that there.
So I'll just chime in with 2 points if I can. I think the first thing about the margins with melanoma is the more of these you do, the more you realize that the margins just don't make any sense. There are times when you're kind of looking and you see another lesion, you know, a few millimeters away. And so they certainly have satellite lesions. And I think that's why a lot of surgeons now kind of temper their belief that they can kind of clear the melanoma. But the second issue is that when you look at the data, even, you know, 10-year survival rate on the SEER study, I think is 10%, but there's still 10%. I mean, some people live. And so, you know, I'm very careful about throwing in the towel on patients. So I think coming back with this patient was the right thing to do. It was still resectable, and you just never know. And you certainly buy them some time, some palliative time, and it's still worthwhile. So I think those are 2 points I would take home with melanoma.
Absolutely. John Almeida, any last comment?
Question for you. I think, and this is probably the most important thing that's going to govern this patient's survival. Forget the surgery for a second, because at the end of the day, surgery is palliative in this setting. It's the systemic agents that's going to get this guy cured, if anything. Is that patient back on immunotherapy after your surgical resection?
He's not on any immunotherapy right now.
And so he's got a response for 13 months with no evidence of distant metastatic spread. Great.
Thus far, yeah. His most recent PET scan was last month with no distant spread to this point.
I'm sure, I don't know if you guys did, but I think most of us at NYU will recommend doing a genetic profile to make sure that if there is any targeted agent, we know about it before it comes out. Okay, great. Then I'll ask Zuka and then Carl, and then we're going to finish.
So my comment is that, you know, there are a lot of nuances in mucosal melanoma, and we shouldn't be using a one type of approach fits all. We all have patients who have mucosal melanoma that keeps growing at the skull base almost like grapes, and you just do the bulking surgery and they never die from the disease. And we get mucosal melanoma where 6 months later the patient is dying from liver mets and lung mets. So there are a lot of nuances. For the fellows, look up pigmented melanoma versus amelanotic melanoma. Those usually tend to have a different behavior, with pigmented melanoma thought to have a better prognosis. Location of the melanoma in the nasal cavity has a better prognosis. Age of the patient. So all those are important factors to take into consideration when you decide to either be very aggressive or be more conservative managing mucosal melanoma.
Okay, great. Carl, we'll give you the last word.
Yeah, I don't know if there's anything more to say other than you look at the whole patient and you say, how can I best maintain quality of life, best quality of life for the longest time for this patient? Sometimes that involves a radical surgery. Obviously, if there's opportunity for being on a clinical trial, that probably makes the most sense. I rely on the expertise of medical oncologists for overall management of these patients.
This was a fantastic session. I could not thank Ken for arranging this. You guys have been amazing. I would take the liberty of inviting all of you back for this next session of Skull Base. This was one of the most educational sessions I had the pleasure of attending. So thank you. In the interest of time, we're going to finish. Join us in a few weeks for the next session of Virtual Tumor World. You're all invited. Thanks again to Ken Bird, with excellent organization.
Good job.
Thank you to Jonathan, Matt, and John for presenting cases, Dr. Sargi, Snyderman, and Fan, and a cameo appearance by Dr. Al Fayed was fantastic. All right, have a great night. I'll see you in a few weeks.
Thank you.
Great job, everybody.
Good night, everybody.
Thanks for having us.
Night.